Over the past decade, we have published over 100 papers on cross-linking technology, and we focused on two things. We wanted to make the treatments more accessible, which means make it faster, accelerate the treatments, and also extend the range of indications from keratoconus to corneal infection. And we coined the term PAC-CXL to show this new indication, which is infectious keratitis. And we realized that with every cross-linking procedure, we do not only stiffen the cornea, we kill virtually everything living on and within that cornea. So in this case, we thought, why do we need an operating theater? Why don't we do this at the slit lamp? And if you have an infection, so a septic eye, to begin with, well, why do you take a septic eye into an aseptic operating theater to perform an antiseptic procedure? That doesn't make any sense. And as a surgeon, I don't like taking infections into the same place I do my cataract surgeries at. These thoughts have led us to the concept of bringing cross-linking to the slit lamp. Fast forward 8 years, we now have the machine ready to be used at the slit lamp effectively.
In terms of performing this procedure, how will this device change the way that cross-linking occurs?
The technical settings of performing cross-linkings are more or less the same that have been used and have been developed for the laying position. What is new is the application at the slit lamp. We believe that this will massively affect the number of people that have access to the technology.
What does cross-linking do to a bacterial keratitis?
CXL does not only stiffen the cornea, it does 4 things at the same time. It stiffens, it increases the resistance to digestion, so by steric changes in the 3D structure of the collagen, and it kills everything that lives in that cornea by 2 different mechanisms. It interferes with the DNA, and pure oxidative stress disrupts any cellular membranes. And we did not realize that these 4 effects happen with every CXL procedure. Also in keratoconus, it's just not that useful. For infection, cross-linking means you kill bacteria and fungi at the same time. I kill irrespectively of antibiotic resistance. And the third effect no antibiotic can do is by increasing the tissue's resistance against digestion, I will probably end up with a smaller scar because the tissue fights the collagenase activity. And this is an added value that probably plays a much bigger role than we think now. And this is also why I believe that PAC cross-linking should always be performed in an infectious keratitis, no matter how small or big it is, because finally there are beneficial effects that help support the effects of antimicrobial.
And so are there any side effects for the patients?
Not as far as we know now, because the whole science behind cross-linking is the technical settings are very similar to the keratoconus settings. So we speak about a new indication of a very well-studied technique with a very well-known risk profile. And what is important, it is not an off-label use anymore. So the device is the first cross-linking device on the market that has full CE mark clearance for infectious keratitis.
What do you hope that this will allow?
We call it democratizing CXL. So with the upcoming of effective epi-on technologies, we've been also working massively on that in the past 5-6 years. I think if you look into the near future, we will be able to do epi-on cross-linking at the slit lamp. So if there is no more surgical gesture that removes the epithelium, then for keratoconus treatment, then the risk profile is even better. And so taking it out from the OR to the slit lamp means democratizing the access, increasing the global coverage.
You believe this will be performed by non-ophthalmologists, by trained medical professionals in due time?
We are steadily working at making the procedure more standardized, and we are trying to omit steps that lead to an increased risk. As for now, when I perform an epi-off procedure, for example, we manage to overcome the use of scalpels, and we use 40% ethanol on a cotton swab that we then use to tap onto the cornea. So the procedure is getting less and less atraumatic and more straightforward to perform.